Welcome to Adapt NCLEX. Are you preparing to take your NCLEX? These 85 questions is going to serve as a mock exams. These are challenging, covering most concepts that shows up on NCLEX most commonly tested. These are recommendations for those who've taken the exams. It may be hard for you, but I believe by the end of this video, you'll master something and be ready to take your exams. Take your pen and paper, stop the video, pick your answer, listen to the way I'm going to answer it, keep track of your score, and at the end of it, I want you to get more than 65. First question, what do you think? This is what you may see on the NCLEX. Very intimidating, but it's a straightforward question. The client with what? Seizure disorder is admitted. I started with Neuro, whether there's a table or not, it does not matter. How do you approach it? A client with seizure disorder is admitted. For each action, select if it is appropriate or inappropriate. Action, keep suction at bedside. Insert oral airway during seizure. Take client on the side after seizure. Apply wrist restraint. Pack bed rails. Obtain IV access. When somebody is having seizures, what do you think you need to know? Seizures are very commonly tested. I want you to master them. What do? Make sure there's suction at the bedside, because then if they aspirate, you have it ready. When you go in seizures, they cannot protect their airway, so you got to have this available. You don't put anything in their mouth during seizures, so this is inappropriate. You turn them on the side after seizures so that they can avoid aspiration. Appropriate. Apply wrist restraint. Nothing restraint should be applied. You should not apply restraint at all. It's inappropriate. You should pad bed rails so that they don't injure themselves. Appropriate. And you should obtain IV access because you may give them IV medication. These are answers you should be comfortable answering based on seizure disorder. I know you get it right. How are you doing? Let's get to it. Number 2, neurology. Read the question from the back. Which intervention is most important for the nurse should implement in a plan of care? About what? A client with what? Left-sided stroke is experiencing expressive aphasia. What do you want to improve? What do you want to include in the plan of care? Encourage the client to speak loudly and slowly. Use gestures and simple language. Write down instruction. Stop the video, pick your answer, and I will give you the concept. Every question, I will give you the concept, and I want you to write it down like you're studying. And at the end of it, you see a bunch of concepts you know. You pick your answer. If I'm taking this test, this is the way I'm going to approach it, to go for the keywords. Most important for the nurse to implement in a plan of care. That means all these are okay, but the most important that you have to be sharp. That means prioritization. The client with the left-sided stroke is having what? Expressive aphasia. What is expressive aphasia? There's 2 things I want you to write. Rat and beef. Right? Beef is what? Bronchi expressive aphasia on the frontal lobe. Rat is what? Wernicke receptive aphasia on the temporal lobe. Patient has what? Expressive. I cannot express myself. They understand what you're talking about, but they cannot speak. Therefore, encourage the client to speak. They can speak. Speak loudly and slowly. They can hear you. You don't need to shout. Use gestures and simple language. They can see and make sense out of it. Write down the instruction. It's okay, but the best one is to use gestures and simple language. 4 may be okay, but it's not the best one. Use gestures and simple language so that you can say yes or no. So this is the best answer choice. And this is caring for a client who was admitted with what? Acute ischemic stroke. Patient has stroke. The client blood pressure is 188/104. And the client is alert, stable neurological finding. The provider has not prescribed antihypertensive medication at this time. Which action should the nurse take? This is testing a concept. Every question I wrote, testing a concept. So you got to write it down. Request the PRN antihypertensive medication to lower the blood pressure immediately. Place the client in a position to improve cerebral perfusion. Continue to monitor the client's blood pressure and neurological status. Restrict all oral fluid to prevent increased intracranial pressure. Stop the video, pick your answer, and let me know. I give you 5 seconds. Actively stop the video and pick your answer because I want you to keep track of your score. What is the question asking you? This is what the question, the concept is what? Action for the nurse to take. There is no prescription provided, but the blood pressure is 188/104, and a client has stroke. What do you think is going on? In stroke, we have something we call permissive hypertension. You allow them to be hypertensive, but not systolic more than 200 or diastolic more than 110. This blood pressure is okay to allow perfusion to the brain because the brain is injured. Therefore, you should not request antihypertensive. You should not place them into Andelic. That will increase ICP, right? Continue to monitor decline and neurological symptoms because this is very important. This is acceptable permissive what? Hypertension. Restricting all fluid to prevent intracranial pressure is not needed. You can give them what? 3% normal saline to decrease their ICP. And therefore, this is your right answer. 3 questions. What is your score? And this is the explanation. You can take a picture of it. But ischemic stroke, we allow permissive hypertension. What do you think? NS is assessing a client who was admitted after a motor vehicle collision. The client is alert-oriented. Based on the image finding, which condition should the nurse suspect? Concussion, basal skull fracture, epidural hematoma, subdural hematoma. I'll show you the image. This is the patient. What do you think is wrong with the patient, and what should you do? What is the diagnosis? Based on what you see, patient involving motor vehicle collision. Key fact, motor vehicle collision, and you see this, you have what? Raccoon eyes, right? You have nose, CSF leakage, right? You may have mastoid ecchymosis here. That's vital sign. What do you think? This is no concussion. There's no change in facial expression, or there's no change in peripheral edema or hemorrhage. Basal skull fracture is the most important one. Epidural and subdural, you got to get a CT to be able to see it. You don't see anything on physical exams. Therefore, this is basal skull fracture. Never put the NG tube in this patient. And this is assessing the client who is receiving IV morphine for post-operative pain. The client sedation score is 3 on what? Postural opioid-induced sedation score. Which action should the nurse take? You may see questions like that. You have no clue, but use the taking strategy. I'm going to show you. Then we analyze it later on. But this is the problem. They say sedation score is 3. That means something is higher, right? Administer the next scheduled dose of morphine. Document the finding and continue to monitor. Notify the provider and withhold open further dose. Administer naloxone immediately. There's something here. There is a scale. I have no clue. I receive morphine for post-op pain. My sedation is 3. What should I do? You have to know sedation scale. But even if you don't know, you can eliminate things. Which answer do you pick? Stop the video, pick your answer choice. I can tell you 1 and 2, you are not doing anything. Patient sedation score is 3. That tell you. If I give you morphine and I say sedation score is 3, that means it's bad. Now, you let the doctor know withhold the medication or give them naloxone. If you give them naloxone, you're just treating the problem. But you may have to give them another dose of morphine. But if I tell the provider, I hold it, that patient is oversedated, this is the best choice. This is the way you take questions, answers regarding these things you don't know. But this is the scale. You can take a look at it, take a picture of it, right? When they give the medication, the patient is sleepy and irritable, it's acceptable. If they are awake, alert, it's acceptable. That's 1. If they're drowsy, but they come back, 2. If you frequently drowsy and drift away, that's 3. That's concerning. If you can't even do anything, there's something said, emergency. This is where you give them medication, naloxone, right? But this is the problem. You give them naloxone if the respiratory rate is low and it's severe hypoxia. So that's the key. Know this and know how to answer this question. And this is for a client with severe cirrhosis. Each of the following prescription should the next question. Select or apply. Acetaminophen, 1,000 milligram every 6 hours. Rifampin, 600 milligram orally daily. Lactose, 30 milligram orally twice daily. Orazepam, 2 milligram IV, 4 hours PRN agitation. Spironolactone, 100 milligram orally daily. When they give you questions like that, I want to put your answer down first. I'll give you the key concept. The way to answer this kind of question, go back to the question. And I know you pick answer, so then I'll give you the information. So select or apply. You don't have to pick everything. The next question, that means something wrong. Patient has cirrhosis. You say, oh, cirrhosis, oh, liver problem. That means I should not take anything that affects the liver. But if there's a medication there that can be used to treat cirrhosis, I will pick it. Right? So acetaminophen is broken down by the liver. It's not good. Rifampin, broken down by the liver. It's not good. Lactulose, if you have cirrhosis, give it to you to prevent encephalopathy. Lorazepam is broken down by the liver. Problem. Spironolactone, we can use it for cirrhosis. Therefore, this is good. Medication will question. Next question. We move to risk reduction. And then receive phone calls from parents of a school-age child 12 days after tonsillectomy. Which of the following statement is concerning? My child is drinking too much water. My child temperature is 101. My child is reporting painful swallowing. My child has a football game scheduled for today. What is your answer? Pick your answer. Let me know. But what is the concept? The concept is what? Tonsillectomy. What do you worry about with tonsillectomy? Bleeding. If you involve what we call football game within 12 days, that's a problem. We should do something about it. And that's a big problem. We should do something. And that's the issue. And this is caring for a client with what leg tube thoracostomy for spontaneous pneumothorax. During assessment of the chest tube system, the nurse note absence of titling. Which action should the nurse take? Clamp the chest tube, notify the provider immediately, evaluate the client breath sound, increase word suction. Go for the bars rate, find the keywords, stop the video, find the keywords, analyze them, figure out the question is asking you. 50% of the question is based on how you answer by breaking down the question. You can see that we're doing prioritization now. This is prioritization. You pick your answer choice? Good. Let me break it down and see how we pick the answer based on making that question. I choose this first. That means all of them I can do, but it's what you do first. Patient has chest tube drainage, right? And there is no absence of titling. This is the chest tube, and this is the individual. The chest tube is connected to the system, right? If the patient takes a deep breath, you see movement. The fluid move in and out, or when you check where the water area, the fluid move up and down. It tells you the system is closed. It tells you the patient is functioning. If you don't see it, something is wrong. You should not clamp the chest tube. That's bad. You should not notify the provider until you figure out what's going on. See if the patient is breathing. Evaluate your breath sound before you check the system. And increase word suction. It has nothing to do with titling. Unless there's no suction in the system, no. But this is your right answer. Did you get that one right? I know you got it because you watched Adapting class. Number 9, prioritization. And this is reviewing client report. Which client should the nurse see first? Be sharp. If you want to know how to answer prioritization, check my YouTube site. A bunch of video free on prioritization. It's called Be Sharp. I have so many videos. You can learn how to do it in a simple way. You don't get trapped. Non-expected finding. What do you see? Who do you see? A client who consumes aged cheese while taking phenoxine. Pharmacology. A client who reports tremor and insomnia after taking metafenidate. That's a psych pharmacology by its prioritization question. A client who has what? Drooling after taking clozapine. This is a hard one. A client who has what? Diarrhea, clonus after taking escitalopram. This is a hard one. But if you get it, give me a high five and put down where you're watching from. If you get this right, I want you to put down, not question 9, I'm watching from where? New York, whatever, and I'll give you 5. What do you think? Who should we see first? Don't get trapped. Pay attention. Not unexpected finding. You have to be sharp. You pick your answer? Let me break it down. Let me break it this one. Prioritization down. Client, he consumed aged cheese. He's taking phenoxine. What is phenoxine? It's a MAOI. You should not eat aged cheese, but he has no symptoms. He consumed it. Well, we should see him But right now, I don't see anything wrong with it. Let's see the other ones. Client report tremor, insomnia after taking metafenidate. It's a stimulant. If I give you stimulant, your heart rate goes up, you have tremor, you can sleep. Patient is having symptoms, but it's an expected finding. If I give you clozapine, it causes hypersecretion. Therefore, on salivation, you're going to draw if you salivate too much. Based on that, you can see that 4 is the right answer. What is the problem? Escitalopram is what? SSRI. If you have diarrhea and clonus, that's what? Serotonin syndrome. This is bad, this is bad, this is bad, this is bad. But this is expected. This one is not having symptoms. Even though they take MOI in addition with HEs, they don't have symptoms. This guy is already having serotonin syndrome. You should pick him. Did you get it right? I said, put down your answer choice and tell me where you watching from. And you can take a picture of it and can see acute neurological instability is greater than potential hypertensive crisis. First one, if you take HEs, you're going to have hypertension. 4 is already having symptoms. Therefore, we should pick them. This is caring for 4 post-op client receiving opiate. Which client should the nurse see first? That means they have issues with sedation. Client with what? Sedation score of 3 and a respiratory rate of 14. That's key. Client with oxygen saturation of 88 on room air and respiratory rate of 88. Client reporting pain 9 out of 10 and requesting additional morphine. A client with nausea and vomiting after receiving hydromorphine. Which one would you see first? Prioritization. NCLEX prioritization. You pick your answer? I know you picked the right one. They all receive opiate or they need opiate. Who do you see? Well, if you have nausea, vomiting after you take opiate, that's expected. If you're requesting additional opiate, where I have time to give it to you. But look at this. This saturation is 88, respiratory of 8. Is having symptoms associated with the problem after receiving opiate. 1, sedation score is 3. It's bad, right? But the respiratory rate is what? 14. Don't only look at the sedation score, but look at it. Even though the sedation score is 3, patient respiratory rate is 14. Compared to this one is what? Patient is hypoxic, and then respiratory rate is 8. We're going to see this one. 10 questions. What is your score so far? Like I said, prioritization. 3 more prioritization questions. NS is aware of 4 assigned client at the change of shift. Which client should they see first? A client with darting tongue movement after receiving peripherism. A client with what? Bipolar disorder who is pacing while eating a burrito. A client with what? Suicide ideation who is being monitored by a 1-to-1 sitter. A client with anorexia who consumes 10% of their breakfast. Who are you going to see? This is a psych, mental health, prioritization. You have to master psych, and this, you will see it in prioritization. Like I said, recommendation. If you can answer this, that means you're on top and you're ready to pass your NCLEX. What do you think? You pick your answer. Schizophrenia, take perfenizine. This is what? First generation antipsychotic. That in tongue is what? Acute dystonia. It can also be element of tardive dyskinesia. Bipolar patient, they pacing, but they eating. Good luck with that. You have suicide ideation. That's bad, right? But what is the problem? We're taking care of you. There's 1-to-1 sitter there. Therefore, nothing to worry about it. Anorexia is not eating his food. Yeah, that's fine. More nutrition. But this patient is having symptoms. That in tongue, you can have airway problem, acute dystonia, what? Element of tardive dyskinesia. They will need benztropine to manage it or anticholinergic. But these should be comfortable for you to answer. This is the key. EPS symptoms. Number 12. NS is caring for a client with chest tube connected to water seal drainage system following a pneumothorax. It does not matter. Patient has pneumothorax. He has chest tube. So many language, so many words. Ignore it. Then is observe persistent bubbling, persistent what? Bubbling in the water seal chamber. Which action should the nurse take? Increase the water suction pressure, clamp the chest tube near the client, check the tubing and connection for leak, and document the finding as suspected. There's a buzzword there. It's persistent what? Bubbling. That means consistent, continuous bubbling. If you see continuous bubbling in the chest tube, what does that mean? It doesn't mean you need to bring more suction. It doesn't mean you should clamp the chest tube. There's a leak. That's the leak. Document the finding. It's abnormal. We should not document it. Last prioritization. The next is aware of 4 clients at change of shift. Which client's situation need follow-up? That means we got to do something about it. Client with emphysema, his saturation is 88. It's okay. Client with hyperthyroidism, his heart rate is 110. Is that okay? Client with amyotrophic lateral sclerosis and inability to cough. Is that okay? Client with pneumonia and a temperature of that. This is what we call prioritization using expected finding and non-unexpected finding. You pick your answer. You pick your answer. If you have emphysema saturation of 88, probably that's where you live. COPD patient, 88, 89, it's normal for them. Hyperthyroidism, everything is up except your weight. Therefore, this is expected. Amyotrophic lateral sclerosis, if you cannot cough, that's the airway problem. And you have pneumonia, you should expect to have temperature. 3 is your right answer. This is a big sharp movement right there. Number 14, pharmacology. I got you. Don't worry. Write this medication down. If you've not seen it, there's a way you can answer them. You look at the answer choice, you look at the key fact in the question, break it down and find your answer. Which of the following prescription the nurse should anticipate from the healthcare provider? And let's provide care for a client with what? Acute bronchitis. Morphine, 400 milligrams twice a day. Umeclidinium, right? 62.5 microgram once daily. Bethemacol, 5 milligram once daily, and pilocarpine, 5 milligram once daily. There's a concept here. It's about COPD patient, acute bronchitis. What medication should you give them? And what medication should they avoid? You pick your answer. You pick your answer. COPD patient, you should avoid what? Morphine. Bethemacol is what? Cholinergic. COPD patients should avoid cholinergic. They should take anticholinergic. And pilocarpine is also cholinergic. Umeclidinium is what? Anticholinergic. It helps with what? Bronchodilation and help getting rid of the mucus because this is what? Acute bronchitis. This is your right answer. In these medications, a bronchodilator helps with secretion, suppresses secretion. So it's very, very important. Pharmacology, right? You got to know this medication. Once again, you got to know this medication. I want you to stop the video, write it down, go read about it. I will give you more concept about it because it's easy on the NCLEX. The show is up all the time. Ethosuximide. Please know it. And next is reviewing medical record of a client during change of shift report. The next notes that the client prescribed what? Ethosuximide. The next should expect the client has which of the following condition? Tonic-clonic seizure, absent seizure, status epilepticus, myoclonic seizures. They all are seizures, but the specific seizures and the specific condition, you can use this medication. You pick your answer. Pharmacology. This is neuropharmacology. I can tell you the most important medication for absent seizure is ethosuximide. That is the key. There's another question in the video that talks about side effects the NCLEX will ask you. You want to stick around and watch it. 15th question. What is your score? Like I said, I would like to know where you're watching from. Put down in the comment section, say, I'm watching from Germany, which country you're from. But I want to know your score at the end of it. Ethosuximide is used for absent seizure. Other medication, anti-epileptic, can be used for all others. But this is specific. That's what we use it for. And this is provide teaching to a child who has what? New prescription for ethosuximide. Like I told you, this is it. To treat what? Absent seizure. Which of the following instructions should the nurse include? That means if you know the medication for absent seizure, what kind of teaching should you provide? Monitor the child for lethargy or dizziness. Administer the medication with food if GI upset occurs. Discontinue the medication once seizure stop. Report fever, sore throat, signs of infection to the provider. Observe for behavioral changes such as depression and mood. I'll show you strategy. But pick your answer. It's a select or apply. You don't have to select everything. Pick those you are 100% confident. If you only know one, pick it. Otherwise, you lose the point. There may be only one answer choice there. You pick it. Strategy. Neuro medication, especially anti-epileptic, they always affect your neuro status. They can affect behavioral changes, and it suppresses the bone marrow. So you see what I did? All of them. Therefore, if you have dizziness and lethargy, you should teach them that. They can cause GI upset, let them know. They should not stop the medication. If they have fever, sore throat, signs of infection, that is what? Myelosuppression. You should let them know. And if there's behavioral changes, it could cause behavioral changes, depression, mood changes, and suicide. This is something you teach the parent. So these are side effects. I want you to know it. Ethosuximide, these are a major side effect. You can take a picture of it. When you see it, you know what to do. 17. Pharmacology. Which of the following findings should the nurse question the prescription for? A nurse care for a client diagnosed what? Ischemic stroke. Prescribe what? Thrombolytic therapy. Will you question if the patient is 60 years old? Blood pressure of 178/90? He has a history of abdominal surgery 13 days ago. He has symptoms onset 4 hours ago. What do you think? You pick your answer choice. There is certain things you have to know about thrombolytic. We give it to patient if they have ischemic stroke. But the problem is, if they have certain condition and you don't check it, you convert them to what? Hemorrhagic. After you give them thrombolytic. So they bleed more and they have more stroke. And what is the problem? Age is not a factor. The blood pressure should be uncontrolled. This is fine. You're talking about something 220/110. Abdominal surgery, 14 days, 13 days is wrong. Stroke onset within 4.5 hours. This is 4 hours, is good. Therefore, if the patient had surgery 13 days ago, you want to do it after 14 days. Therefore, this is a key concept. And let's administer midazolam IV bolus to a client before a procedure. The client blood pressure is now 86/40 and heart rate of 130 beats per minute. Which prescription should the nurse administer? Naloxone, morphine, flumazenil, atropine. Pharmacology is usually, if you know how to approach it, easy. You know the medication we give them. Patient is having symptoms. What medication are you going to give them? You give them something, they are in trouble. What would you give them? Patient get what? Patient get what? Benzos. And now they're bradycardic and tachycardic. You should take away the benzos. Naloxone is for the opiate. Morphine will make the patient heart blood pressure drop more. Flumazenil is an antidote for what? Midazolam. Atropine is going to make the heart rate increase. This is your best answer choice. And let's provide care for a client receiving IV lidocaine during a skin biopsy in the clinic. Client immediately become confused, drowsy, periorbital numbness, and metallic taste. Which prescription should the nurse anticipate? Isotonic infusion, metoprolol, lipid infusion, and phenotide. It sounds difficult, but it's not. So pick your answer and I'll show you how to break it down. It requires you to think critically, bring your common sense strategy. As usual, at that NCLEX, we try to bring some common sense and say, hey, what is going on with the patient? I give them 1% lidocaine. I've given you a medication, so pay attention to that. And the patient all of a sudden, confusion, drowsy, periorbital numbness, and metallic taste. That tells you this is toxicity of lidocaine. How do you treat toxicity of lidocaine? What do you think? It's not isotonic infusion. It's not metoprolol. It's not phenotide. You give them propofol. That's lipid infusion. This is a must know. If somebody have lidocaine, local anesthesia toxicity, give them propofol or lipid emulsion. Key concept. And that's what? Provide teaching for a client, prescribe the following medication and discharge to several clients. Which client teaching is appropriate or not appropriate? You have a bunch of patients, they provide them teaching, which teaching is appropriate. One as lithium. The next said increase sodium-rich diet intake. Another patient has warfarin. It said increase vitamin K-rich diet. Digoxin, it said increase potassium-rich diet. Thenzaparin, it said avoid vitamin K-rich diet. Phenotine, ensure high-protein diet. Atorvastatin, take the medication in the morning. Which one require appropriate or not appropriate? That's all. That's what it's asking. Atorvastatin, inappropriate. You take it in the evening. Phenotine, you should not eat too much protein. Inappropriate. Thenzaparin is heparin. Heparin, you don't need to change your diet. Inappropriate. Digoxin, don't increase potassium or decreases. Inappropriate. Warfarin, don't increase your vitamin K rich diet or not. And lithium, same amount of sodium rich, not above or below. This is the way you answer it. This is the concept. Take a look at it. This is the way the NCLEX will trap you. For any questions, where are you watching from? Put down the name of the city or state where you're from. And what is your score right now in the comment section. But this is Adapt NCLEX, NCLEX practice question, NCLEX review question, NCLEX questions and answers on commonly tested questions that shows up on the NCLEX. And this is the mock exams. I want you to get 65 and above. That means you're doing great. And we have all kind of questions from case studies, NGN, everything you need. Are you ready? Let's continue. And if you're tired, go get something to drink and come back because we're going to go through these questions. And I know by the end, you learn something. 21. What do you see? Cardiology. Which of the following defects should the nurse identify as the cause of what? Right to left shunt. A nurse is providing teaching to a newly licensed nurse about congenital heart defect. Which one is right to left? That means what? Cyanotic baby. Patent ductus arteriosus, atrial septal defect, transposition of great vessel, ventricular septal defect. Pick your answer. When you see questions like that, straightforward. This question is what? Anything that starts with the T is right to left. If you don't start from T, then it's left to right. There's no T starting. This is A, this is V. This is your right answer. You don't have to know details, but we call them the blue babies. The blue babies always start from what? Right to left. Questions? I know you got it. If you need more, check Adapt NCLEX. This video I have on this, I will make it straightforward. You understand the concept. But for this 85, I'm giving you the concept you need to answer the question. Straightforward. All you need to know. Single one or two information to answer the question. Next generation NCLEX. Like I told you, this is a hard one. If it's hard, I intentionally did lightweight because that's what I got. Information about what is showing up. And this is the way I want you to think about. And let's provide care for a client with what? CVP of 20. Which assessment finding the nurse should expect or not? CVP of 20, what does that mean? Central venous pressure. Long crackles, skin tenting, what? Thready pause, cold skin, hypotension, capillary refill greater than 3 seconds, periorbital edema. I'm not saying you're going to get these questions, but the concept, that was the concept I got, and that's the way I create the question. This is asking you about CVP, central venous pressure. Pick your answer, let me know which one is suspected or not. But before you answer it, always go for the concept. CVP of 20 is too high. Your normal CVP is usually very low. Within 4 to 8 is not too high. If you are within 20, that means you fluid overload. If I'm fluid overloaded, what am I going to see? Lung crackles. My skin is not going to tent, right? It's not going to do that. Not expected. My pulses is not going to be thready because I'm fluid overloaded. My skin is not going to get cold. My blood pressure is going to go up. Capillary refill should be less because I'm fluid overloaded. And periorbital edema, expected finding. This is what you see when it comes to CVP, that is high and fluid overloaded. This is how the NCLEX asks you questions about fluid management, and you have to apply it. You're not going to ask you a straightforward question, you just apply it. This is fluid overload. 23. You can see we move to respiratory. Which of the following findings should the nurse identify as a possible cause? Select or apply. A nurse is caring for a client with ARDS who is mechanically ventilated. The nurse notes multiple low pressure alarm on the ventilator. Which of these conditions will cause low pressure alarm? Pneumothorax, surface tubation, king tube, client biting the tube, mucus plug, and leaking ET tube. All of them try to look for the concept. Like I said, this is the way you answer question. You go for the buzzword, select or apply. You don't pick everything. It's a possible cause. That means not all of them. What is the key fact? Low pressure. And when you have ventilator to the patient, low pressure means there's a leakage. That's all. Our patient does not have the tube anymore. Therefore, look for low pressure. If you have pneumothorax, there's high pressure. If you self-extubate, low pressure. If there's a kink, there's a blockage, high pressure. If you bite in tongue, the tube, high pressure. If there's a mucus plug, there's high pressure. If there's a leak, low pressure. Two answers. Over select, you get 0. Don't pick too much if you don't know. Just pick you're 100% sure. This is the Generation NCLEX. You don't have to over select when you see select or apply. Don't be greedy. Only 2 answers there. That's why you got to use the concept to answer it. Which of the following findings should the nurse be most concerned about? The nurse is admitting a client with diagnosis of what? Mucoviscidosis. I'll show you why this is the name I put over there. I did not want to put the name that everybody knows. Oxygen saturation of 89 on roommate. Serum albumin is 2.9. Excessive thick blood thin sputum. Large, bulky, foul smell is 2. Which of the following should the nurse be most concerned? That means all of them is bad, but one of them I should worry about it. Which one? You pick your answer. Pick it and let me know where you're watching from. But mucoviscidosis is cystic fibrosis. That's all. Mucoviscidosis, cystic fibrosis. Which finding is concerning? Saturation of 89. What do you think? Patient is hypoxic. Malnutrition. Is it going to kill them right now? Excessive blood thin sputum. He has mucoviscidosis. Large, bulky, foul smell is 2. Expected finding. If you're hypoxic, I should worry about you. So this is the way you do prioritization regarding respiratory problem. All these things is expected, but it's one that is worrisome. Patient is hypoxic. We need to give them something. And what do you see? ABG. What do you need to do? Read the question. What do you need to do? Find the buzzword. Don't be defeated. You can answer this. The novice nurse will anticipate which prescription from the care provider. The novice nurse provide care for a client with acute respiratory distress syndrome on a full ventilator. This is the ABG. pH 7.29. CO2 is 32. Bicarb 19. PO2 90. What would you do? Increase the fraction inspired oxygen. Keep head of the bed at 30 degrees. Increase the respiratory rate and decrease tidal volume. Before you answer this question, you got to rewrite it and interpret it. So what is the ABG? pH of that. This is acidosis. I see bicarb of 19. That means metabolic acidosis. And what? The CO2 is down. That means I'm trying to compensate. Therefore, what do you think we should do? What do you think we should do? The patient is already doing that. So you have metabolic acidosis. We can repair it doing what? Respiratory opposite acidosis, you put alkalosis. What is alkalosis? The patient is trying to do it to compensate 32. That means we got to increase the respiratory rate. Therefore, increase the respiratory rate. If you decrease the tidal volume, you're going to increase more acidosis. You create what? Respiratory acidosis. We want respiratory alkalosis. Keeping the head of the bed at 30 degrees is not helping us. Increasing fraction in inspired oxygen, saturation is what? 90%. There's nothing we can do. And this requires some critical thinking, ABG. This is the kind of ABG you want to do. You don't want to just know the norms, but I want you to know what you do to help the patient increase the respiratory rate. Same thing, ABG. The nurse is in the emergency department, is caring for a 6-year-old client by a parent after injection, unknown quantity of aspirin. Some of these concepts you know, but they will use questions to create it. You know what ABG you should expect when you have aspirin injection. That's what the question is asking you. The client report nausea, vomiting, ringing in the ear. They have symptoms. I'm trying to simplify it for you. The nurse review the ABG. Which one should you expect? Rewrite the question again. It means aspirin overdose. What should you expect? Think about it. The patient is going to breathe very fast, right? That means CO2 is going to go down. Therefore, number 2 is gone. Number 3 is normal. And number 3 is higher. That means they're not breathing fast. Just by that, you're supposed to get what? Patient is going to breathe very fast. And you're going to have an alkalosis. The only thing that is alkalosis is that. And therefore, you can see CO2 is 28. That means we're blowing up and we're compensating with that. This is your right answer. This is the way I want you to think about it. They breathe very fast. They will lead to respiratory alkalosis. And that's the way you do it. And this is teaching a client of a child with a persistent asthma. Which instruction should the nurse include? That means they have asthma. How do you prevent it? Avoid known allergies and triggers. Teach proper inhaler technique and spacing. Encourage the client to exercise without precaution. Monitor peak flow daily and record results. Stop taking controlled medication once symptoms improve. Some of these answer choice, you can know that this is what they will do to you. It looked like abnormal. Ignore it. The best way to prevent asthma, avoid allergy. You teach them proper technique. They should exercise with precaution, and they monitor their peak flow. They should not stop their controlled medication. Those are your right answer. 28. I love this question. If you get it wrong, it's okay. I'll show you how to do it. It's straightforward. But I want you to put your answer down, number 28, what you get for this. A 12-year-old child with asthma has a personal best peak flow, of 400 liters per minute. Today, the child reading is 260. How should the nurse interpret this? Continuous usual treatment, caution, adjust medication per asthma plan, seek immediate medical attention, and then D is normal, no action is needed. What do you think? Look at the values I've given you. There's a clue there. It was 400 as their best, and it's 260. What does that tell you? Stop the video, pick your answer, and let me know. But if you look like the 400, this is normal for you. Now you're going to 260. This is like almost half. That means they are in the 50 to 70 range. That's yellow, right? That's bad. Therefore, if they are in the yellow range, what should you do? What do you do? Caution, adjust per asthma protocol. That's the thing. You shouldn't continue usual treatment. It's not in the red zone. It's not less than 50. And this is not normal. And therefore, we should caution and adjust medication. This is a yellow zone. And that's based on the calculation. If you divide, you get 65. So that's the key. And that's how you answer this question. And this is caring for a client with ARDS or mechanical ventilator. Which finding indicate complication? The most common complication with ARDS is what? One, pneumothorax, and what? Increase intrathoracic pressure. Therefore, what is your right answer? Oxygen saturation remain 92 on FiO2. Increasing peak airway pressure, PO2 of 80 on the 60%, and the lung is clear bilaterally. If there's too much pressure in the airway, it causes complication. It causes decrease in cardiac output. If there's airway pressure, you can have pneumothorax. So this is your right answer. 30. What is your score right now? 30, 30, 30, 30. I know you're doing great. Which fluid choice is most appropriate for the client? Fluid electrolyte. You see, we move. I told you this concept. It's a bunch of topics you're supposed to know. If you need help, check out that NCLEX. And this is caring for a client with what serum sodium of 155. That's hypernatremia. What fluid would you give them? 3%, 0.45%, 0.9%, 5% dextrose, plus 0.9% normal saline. Concept put together in this question, apply common sense, and they say, look, what do I need for hypernatremia? Do I give them more sodium or take away sodium? That's all. This patient should not get any more sodium. If you're not going to get any more sodium, 3% is too high. 0.5% is much better. Normal saline is too high. This is the same as normal saline. This is hypertonic solution. You should not give it to them. 31. Let me know what is your score so far. And this is caring for a client with admitted 2-year-old with pyloric stenosis after 72 hours of projectile vomiting. A 2-year-old is been vomiting for what? 72 hours. That's a lot of fluid lost. Dehydration. Which electrolyte abnormality they need to anticipate in the admission laboratory results? Select or apply. This is when they give you pyloric stenosis. This is what they're going to give you. There's a classic lab work you see when the patient has pyloric stenosis and he's vomiting, they vomit acid. If you vomit acid, what is going to happen? You get dehydrated. Your sodium decreases. Your chloride is also decreased because what? You're losing acid, hydrochloric acid or normal sodium chloride. You become what? Metabolic alkalosis. Therefore, your bicarb increase. Your potassium is going to decrease due to what? The sodium to be able to retain. The kidney now will have to retain sodium because you were losing sodium so that you don't get too much dehydrated. So this is what you see. Decrease potassium, decrease chloride, increase bicarbonate, and decrease sodium. Decrease potassium, decrease chloride, increase bicarbonate, and decrease sodium. So this is what you will see in this situation. And this is caring for a client who has what? Experienced severe dehydration for the past 3 days. The next review the client ABG. Which of the following ABG findings should the nurse expect? This is not what? Vomiting, diarrhea. What does it lead to? Vomiting lead to metabolic what? Alkalosis. Therefore, if you have diarrhea, it's different. You have metabolic what? That's the key. Metabolic acidosis. Which of this is metabolic acidosis? I see acidosis. I see alkalosis. This is no alkalosis. This is acidosis, but the bicarbonate is normal. Therefore, this is the right answer. And as I review the clinical data, the next you recognize the client most likely experiencing what? Click on. A 35-year-old client is brought to the emergency room after 4 days of non-bilious emesis. He's been vomiting. Same thing. I wanted to give you all the areas they may give you. He denied diarrhea, just vomiting, no recent travel. Fatigue, feeling of room spinning. Those are the bad words. If I'm vomiting, I'm room spinning, I'm orthostatic, I'm hypotension. And I have dark and pungent urine. That means dehydration. I'm showing you how to read case study. Your respiratory at 15, saturation 97, tachycardic, and slightly hypertensive. Your pH show what? Metabolic problem, right? What do you think? Metabolic alkalosis, consistent with what? Vomiting. Now, what is the nurse is going to recognize the client most experiencing? Metabolic alkalosis. What are you going to give this patient? What do you think? Encourage hyperventilation, immediate intubation, oxygen via face masks, normal saline. Think about it. Saturation 97. Why do you want to give them oxygen? Patient is being vomiting. He has dehydration. Therefore, normal saline bolus. This is a straightforward next generation NCLEX question. Next generation NCLEX. Like I told you, this is a hard one. This is a C type question. You got to go through it. Don't worry. There's key ways to answer this question. Go for the bars rate. Figure out what is wrong with the patient. And I know you can get it. 17-year-old female, bars rate. 2 days of nausea, right lower quadrant pain, chills. No sick contact. Last menstrual period was what? 1 week ago. So menstruating, sexually active. No prior episode of pain. Normal bowel sound. And no more bowel movement. No urine symptoms. Sexually active. Not on oral contraception. Temperature high. Tachycardic. Blood pressure is okay. Saturation 99% on room. Patients are lead-oriented, right? S1 present. Peripheral pulses is fine. When you examine them, abdomen is slightly distended, and there's tenderness at McBurney's point. No bruit on the spleen or the liver is not enlarged. Just by reading this should tell you something. You should be able to make diagnosis. Go back. I don't want you to look at the question. Read the question again. Find the bars rate. Make a diagnosis. As soon as you know what is wrong with the patient, the case is easy. If you don't know what is wrong, even if they don't ask you what it is, it becomes very complicated. So that's what I want you to pay attention to. 17, female, right lower quadrant pain. Here, at the McBurney's point, there's no vaginal discharge, nothing like that. She's sexually active as menses a week ago. McBurney's point tell you this is what? Appendicitis. Now, if you know this is appendicitis, the rest is history. Appendicitis. It can be atopic because they have to tell you the patient has what? Vaginal discharge, or pain is referred to the shoulder. It can be cholecystitis because it has to be right upper quadrant. It can be diverticulitis. It has to be left lower quadrant. None of them is in the case. Which intervention is appropriate? Every GI problem? What do you think happened? The patient is not happy. He has pain, nausea, and vomit. He's not going to eat. Right? Therefore, why would we give them clear liquid dye? Negative. NPO. If you NPO, you get an IV fluid. They will need some antibiotic. You got to manage their pain. They are not ready to go home. Don't discharge them. Once again, stop the video before you let me give you the answers. The client underwent surgery, right? Which of the following the nurse should anticipate in the plan of care? After they remove the appendix, what do you think we're going to do? Clear liquid diet, ambulate 3 times a day, bed rest, SEDs, and pain management. Well, nobody has surgery and they don't need pain medication. We got to prevent DVT. They should be walking. They should walk. B and C contradicting each other, and they can eat clear liquid dye. Which teaching and discharge is appropriate? Take shower, take bath, no heavy lifting restriction, follow up as needed. Well, they got to come back. They can't be follow up as needed. Right? They can't be follow up needed. They cannot take bath. There's weight lifting restriction. Therefore, shower is okay. The client presents 3 weeks later. Now he has right lower quadrant pain, nausea, and vomiting. Now there's vaginal spotting now. That's no more appendicitis, right? Tachycardic, hypotensive. This is ectopic pregnancy. Which of the following is appropriate? Well, they may be bleeding. Check TBC. Basic metabolic panel. It's not important, but we still need it. Urine culture, okay, if there's infection. But the most important is to figure out if they're pregnant. You have to priority. CBC is fine. Are they bleeding? Fine. But if you don't know they're pregnant, so we got to make sure they're not pregnant. That's the key. Now, what are we going to do? Based on the diagnosis, prioritize the following. Which one would you put in the plan of care? Right? If you're going to have surgery, it's going to be the last one, respiratory laparoscopy. They will need consent before they can go to surgery. They will need CT scan, right? We got to transfuse them, right? So we got to transfuse them. When we're transfusing them, what do? First, what are you going to do? This should say 2 large bore IV. right? And then what are you going to do after that? Type and screen them. Then you transfuse them. You get a CT scan. Why? You got to resuscitate them before you do it. Then you get a consent, and then they do surgery. This is what you do when you see a patient with ectopic pregnancy. Now, this is musculoskeletal. You got to be careful. You want to master this concept, because if you get them, trust me, they're straightforward. If you need more, check out that NCLEX on musculoskeletal. I have about enough questions to get you thinking. Which of the following findings should the nurse expect on assessment? What is the problem? The nurse is caring for a client who sustained fall. The provider prescribed strict what? Spine precaution. That means spine precaution. Which one should you expect? It means, why should the doctor prescribe spine precaution? That means there's something associated with the patient. So you have to know the criteria for spine precaution. Open femur fracture, client is 50, thoracic spine tenderness, elevated blood alcohol level, confusion, unable to move the leg. It's a selected apply. If you don't have any, you don't have an idea, pick those that it makes sense. If I'm dealing with somebody's spine, that means there's a fracture there. I don't want to cause spinal cord injury. So which of this will be consistent with that? Why I will institute spine precaution? You pick your answer already? Now I'll give you the clue. Write down NSAID. This is why we take NSAID for back pain. The N is a neurological problem. You see N there, neurological confusion, or unable to move the leg. S is what? What do you think? Spine tenderness. Excellent. A is what? What do you think? Alcohol, intoxicated, impaired. And then I and D, what do you think? Distracted injury. If there's a distracted injury, that means there's something going on that will distract you from your spine. You focus on it. Femur fracture is the problem. The age, which is sometimes can be A, you want anything more than 60. Therefore, let me make it easy for you. NSAID, open fracture is a what? Distracted injury. Client has to be more than 65. Thoracic spine, spine tenderness. Alcohol level is bad. They will be confused. And they're unable to move their extremities. Neurological deficit. And this is what you do. Take a picture of it and use it, right? Neurodeficit, spine injury, significant trauma, altered confusion, intoxicated, distracted injury is what you use for NSAID. Same thing. Next generation NCLEX. But this is the problem. Musculoskeletal. You have to know the difference between osteoporosis, what? Osteomalacia or Malaysian. I made a video on this and emphasize musculoskeletal. You can watch that. But this is a key concept. Which one? Vitamin D deficiency, bone pain, muscle weakness, decreased bone density, bone softening, fragility fracture, and hypocalcemia. There's something specific about osteoporosis and osteomalacia. When you see this question, don't panic. Which one is associated with it? You have to know the concept. Osteomalacia is due to vitamin D deficiency, and these vitamin D deficiency lead to lack of calcium absorption. In the process, you cannot make bone, you cannot mineralize bone, and so bone is soft. This is the concept. So vitamin D deficiency, your bone is going to have soft and painful, and then softening, and your calcium is going to go low. But osteoporosis is not due to calcium. The calcium level is normal. The problem is you absorbing too much calcium that your body cannot make calcium, cannot make bone. And therefore, the reabsorption is more than laying down bone. In the process, you have what? Density decreases. And you, whenever you fall, a little bit of fall, you have traction. Know this. There's more questions on this to emphasize this. So you want to stick around to understand the difference between osteoporosis, and osteomalacia. And let's provide discharge teaching to a client who sustains severe ankle sprain. Which of the following instructions should the nurse include? Rise, right? That's the key. Limit movement of the injured ankle for the first 24 hours. Rest in it. Apply cold pack to the what? Area for 15 to 30 minutes, 20 minutes at a time, right? Ice. What do you think? Use an elastic compression banding over the ankle. Compression. Keep the leg elevated above the level of the heart. Elevation. Dorsiflex the foot repeatedly while sitting. You should not do that in the first few hours. Therefore, this is rise. And that's the key. Rest, ice, compression, elevation. 38. And then scale for a client who involved in crash injury. When involved in crash injury, muscles are dying. The next is suspect rhabdomyolysis, which finding is most likely. If you have rhabdomyolysis, muscle dying, are you going to have muscle pain and weakness, hypokalemia, decreased serum creatinine, and pale urine? What do you think? This requires some thinking. Don't overselect or don't just jump. Think about it. Rhabdo, muscle dying. If muscle dying, they release their content. Potassium is going to increase. The urine is going to be dark. The creatinine kinase increases. Therefore, you're going to have pain. Therefore, you're going to have pain. And therefore, what are you going to see? Muscle pain and weakness is consistent with that. A client received Botox for treatment of severe migraine. Which potential complications should the nurse monitor for? Common sense strategy. This is a common sense. Difficulty swallowing, hypoglycemia, hypertension, tachycardia. Sometimes they will give you a bunch of bad things that may not answer the question. That's the purpose of this. Botox is going to paralyze things. If I paralyze things, it has nothing to do with hypoglycemia or hypertension or tachycardia, difficulty swallowing, airway problem. You should monitor the client for that. And nurse is reviewing physician order for gallows traction for a client. Which findings should the nurse assess before implementing the order? There's certain things associated with gallows traction. You have to know if all of them satisfy before you can institute. 2-year-old, weight 30 pounds, traction 5 to 10 pounds, no cervical spine injury, no neurological deficit. What do you think? When you have to implement what? Gallows traction is designed for 2 to 3-year-old kids. They have to be maximum 30 pounds. The weight of the traction, 5 to 10 pounds. They should not have cervical injury. And there should be no neurological deficit. These are questions I want you to pay attention to. Write it down. Gallows traction. These are the conditions you have to satisfy before we can give it to you. And this is assessing a 68 years old with post-menopausal, right? Client who report there's a loss of height, recently sustained a wrist fracture after a minor fall. Those are your buzzwords. What should you suspect? This is what you should look for when you're reading a case study or standalone question on osteoporosis musculoskeletal. These are the things. Loss of height. Now the individual has compression fracture. He fell, the wrist, just a minor fall. This is fragility fracture. And it's postmenopausal. Whenever you see postmenopausal patient and they tell you they have minor fall, think about what? Osteoporosis. Don't overthink it. Osteomalacia usually will not have minor fall problem, right? They're going to have bone pain. Now, which disorder should the nurse suspect? Same thing. A nurse is caring for a 52-year-old client who report diffuse bone pain, muscle weakness, vitamin D deficiency. Which disorder should the nurse suspect? The key word is vitamin D and bone pain, muscle weakness. Vitamin D, I know it can be osteoporosis. I have bone pain. There's no mention of what? Perimenopausal, right? Menopausal, anything like that, right? And this patient is older. It cannot be ricket. And it's not hyperparathyroidism. Usually they have renal problem. And therefore, this has to be osteomalacia due to vitamin D deficiency. Now, We're going through all of them. Now we have a kid who has bow-legged. That's the key. Kid bow-legged, growth retardation. This is what? The child has a history of inadequate vitamin D intake. This is the one you see. It's the same thing as osteomalacia, but usually you find it in kid. Therefore, that's rickety. Know them. I want you to spend time on them. Take a picture of it and know the difference. Make a table for yourself and see if you can find the difference. I've given you the key. And the last one, and it's caring for 62-year-old. Pay attention. Postmenopausal client who report, even though it's postmenopausal, what is the problem? Diffuse bone pain. Osteoporosis will not cause bone pain. Muscle weakness, difficulty walking. Laboratory results shows what? Low vitamin D level. The presence of vitamin D deficiency make this not osteoporosis. This patient is too old to have rickety. There is no signs of infection, osteomalacia. You see what we've done? I've given you all the things. Like I told you, these questions are concept so that you can master it. Are you ready? Are you tired? Take a break. Go get something to drink. Take a break and come back. But I want you to finish. Relax. We're going to get it. Next generation. What is the problem? Just read it. 8 o'clock. Post-op day 3. He has a splenectomy. And he's able to ambulate to the corridor 3 to 4 times daily with minimal assistance. Is that good? Yeah. Client has clear breath sounds and left-sided chest tube in place. They put a chest tube in it. There is tightening in the water chamber noted in the deep inspiration, right? Client refused to use incentive spirometer. Is that a good thing? Instead, it causes left-sided chest pain. That means his pain is not well controlled. The client is prescribed PCA and is using it every hour and continue to have nausea and vomit. There's adequate urine output. Abdominal incision is reading with dressing clean, intact, no signs of infection. Findings below that indicate the client is not improving post-surgery. Well, there's tightening in the water chamber. That's good, right? What do you think? Just let me know what you think about that. He ambulates 3 to 4 times a day. That's good, right? He's not using incentive spirometer. He's not improving. He's using a lot of pain medication. That's not good. His urine output is adequate. And he has a bunch of nausea and vomiting. This is indicating that they're not doing well. And so that's what we're going to select. This is GI questions. Elimination. You have to know some elimination. It's a key concept NCLEX asks. And this is caring for 4 clients. Which client should the nurse assess first? Client receiving opiate who had not had bowel movement for 2 days. Client with diarrhea reporting 6 loose stool in the 24 hours. The client with spinal cord injury who report abdominal distension and no bowel movement for 5 days. The client requesting a stool softener. Who is in trouble? Based on elimination, GI concept, GI next generation NCLEX. What do you think? GI next gen. What do you think? Well, receiving opiate, you have not had bowel movement for 2 days. It's not good, but somebody who has diarrhea, 6 loose stool in 24 hours is also not good. But a spinal cord patient who has constipation, abdominal distension, can go into what? Autonomic dysreflexia. 1 and 2 are bad. 3, 4 is okay. But all of them are bad, 1 to 3. This patient, if you don't do anything, they get into trouble. And this is providing care for a client with new colostomy, which finding require intervention. You have to know how to take care of a colostomy. Like I said, this is elimination, NCLEX review. The stoma appear pink and moist. Is that what you expect? Skin around the stoma is reddened and whipping. Is that what you expect? Output is liquid during the first 24 hours or 48 hours. The stoma appear dusky and dark. Is that okay? Client report mild gas in their pouch. Elimination, GI concept. Require intervention. A moist stoma is okay. Skin of the stoma is reddening and weeping. Do we have to be okay with it? No. Output is liquid. That's what you expect. The stoma is dusky and dark. Bad problem. Small gas is okay. So those are the elimination expected finding in a stoma. Which action best prevent catheter-associated urinary tract infection, CATI? And this is caring for a client with indwelling catheter. What do? Disconnect the tubing to obtain urine specimen. Keep the drainage back above the level of the bladder. Do you think you want to do that? Perform peritoneal care daily and after bowel movement. A, cleaning the patient up, irrigating what? The catheter every shift. What do you think? This is key, a key concept. What do you think is going to help? A, peritoneal care is much, much better. Hygiene. Which statement indicate understanding of what? And this is teaching a client with chronic constipation about non-pharmacological. So you got to know non-pharmacological way of teaching what? Preventing constipation. No medication, just changing what? Physical activity and other things. I will increase my intake of whole grain and vegetables. I should limit my fluid intake to prevent bloating. I will try to walk 20 to 30 minutes daily. I should ignore the urge to have a bowel movement. I can establish the routine time to use the bathroom. Non-pharmacological. Non-pharmacological. It's good to establish your routine so that when you're ready to go, you go. You should not defer defecation. So you should not ignore the urge. Walking is good and increasing your fiber. You should drink a lot of water. That will help with that. And this is caring for a post-op client who has not voided for 8 hours. The client reported lower abdominal what? Pressure. Is the bladder distended? What do? Which action should the nurse take? Encourage oral fluid intake, perform a bladder scan, insert the Foley, notify the provider. There's so many things you can do in this situation. Do you want to call the doctor? No way. You'll be mad. You insert the Foley. You don't know the problem. Bladder scan. Case study. Case study, you cannot run away from it. You're going to get it. And when you get it, be comfortable. Don't be disappointed because most of the information is given to you. If you can make a diagnosis and come up with a plan, you'll be fine. Client has what? Congestive heart failure, exacerbation 7 days ago. You know that, right? CHF exacerbation. He has hypertension, hyperlipidemia, CHF. He was discharged home of what? Bumetanide, loop diuretic, atenolol, beta blocker, aspirin, and digoxin. Client report being what? Comply with the medication. He says, I'm taking everything. I feel tired all the time. Am I dehydrated? The room is spinning. Well, dehydration, hypotensive, and you have it orthostatic. Temperature 98, heart rate 89, blood pressure that, respiratory rate and that. There's no chest pain, no palpitation, anything. Exams, clear bilateral to auscultation, the alert, no murmur, there's no edema, and pulses are fine. I've highlighted some information. That means you got to figure out if it's a bad problem. That's all. Which of the highlighted findings are concerning? He has CHF exacerbation 7 days ago. That's bad. He has history of hypertension, hyperlipidemia, and CHF. Well, that's his history. We're not going to change anything. Client report being compliant with this medication. That's good. He said if you're tired and the room is spinning, his heart rate and blood pressure is fine. But those ones is require concerning features. The next, understand that the client may be experiencing orthostatic hypotension due to what? It has to be loop diuretic, no aspirin, no beta blocker, loop diuretic due to dehydration. Which prescription the nurse should anticipate? The patient is dehydrated, is on loop diuretic. What do you think we're going to do? We got to check the electrolyte and see that potassium is not low. Liver function test is not going to help us. Urine analysis and chest x-rays, no, it may help us. The basic metabolic results is shown below, right? This is what you have. Sodium, right, is normal. Potassium is low. Chloride is low. BUN is high. Creatinine is high. Glucose is normal. What do you think is going on? If sodium is low and potassium is high, low, sodium is low normal and potassium is very low, we have a problem. Which of the following is indicated? Select two options. Do we want to stop bumetanide because he has exacerbation? Patient has exacerbation. We're not going to stop it. You need to monitor daily pulse check before medication administration. Which one? Digoxin. Avoid potassium-rich diet. Well, if potassium is already low, we should not do that. Add supplementing potassium because the potassium is low. You should monitor for metabolic acidosis. What do you think? And add sodium polyestyrene. We don't need to do that. Polyestyrene is going to decrease metabolic acidosis, would decrease potassium. So we should not do that. This is a little bit difficult in terms of the answer choice regarding that, but this is talking about hypokalemia and hyperkalemia treatment. Now, same thing. Now the potassium is high, 5.6. Chloride is normal. The only thing abnormal is potassium. What are you going to do? Which of the following the nurse should anticipate in the plan of care? That means how do you treat hyperkalemia? You need an EKG. You need a cardiac monitor. They don't need dialysis now. Insulin will be needed. Dextrose to push the insulin, the potassium in. They will need albuterol. And you should avoid spironolactone because it causes hyperkalemia. Patient potassium is 5.6. This is fluid electrolyte questions testing your knowledge. Based on the suspected diagnosis, the nurse should anticipate which finding on the EKG. Once again, stop the video and answer the question on your own. I know I'm answering them, but I want you to stop it before you, so that you can answer them on your own. If you have hyperkalemia, based on the suspected diagnosis, the nurse should anticipate which finding on the EKG. Pick T-wave, because what? We have hyperkalemia. NS Generation NCLEX. I know you mastered them because this is what? The fluid electrolyte, but you have some cardiology associated with it. If you mix any of them, I want you to go back and pay attention to the concept associated with it. What do you think? We're on delegation. How much do you know? Management of care. You can't get away from it. Management of care. Prioritization. And what? Delegation. And what? Infectious control. The NCLEX is going to ask you. And safety. Which task should be safely delegated to LPN, MMR most? Most medication, monitor, reinforce are the key. And special tests. And this team consists of what? RN, LPN, UAP in the care of a postpartum client 2 days after vaginal delivery. Which one should we give it to LPN? I want you to write this down. When you have three people, everybody stay in their lane. I know LPN can do some of the things of the UAP, but if the UAP is there, no. RN do what they're supposed to do, right? Eat, right? Evaluate, assess, and teach. Therefore, LPN, assess funders is the RN. Assist with what? Ambulation, that's UAP. Teach breastfeeding technique, that's what? RN. Administer oral medication, that's appropriate. Most medication. This is the way you answer it. Don't let the NCLEX distract you. If there's three people there, everybody stay in their lane. Same thing. I'm going to go there so that you master them and watch this portion of the video multiple times. Which task can be safely delegated to a UAP? An SE team consists of LPN, RN, and UAP in the care of a client with a heart failure who has stable vitals on a diuretic. What can a UAP do? Monitor daily weight and report significant changes. Give the patient IV furosemide. Reinforce low sodium diet teaching. Assist the client to ambulate in the hallway. What do you think? Which one is the most appropriate? They can measure the vitals and the weights, but monitoring require the LPN. Somebody will say, yeah, they can do that. But remember, it said safely, right? This one here, they can ambulate the client easily without any ambiguity, right? The word monitoring, we give it to what? LPN. Who's going to give IV furosemide? What do you think? Reinforce low sodium teaching, that's LPN. This has to be done by the RN. So pay attention to that. Which task is appropriate for the RN? Patient has COPD and his oxygen saturation is on 2 liters. Suction the tracheostomy as needed. Assist the positioning for optimal breathing. Teach per-sleep breathing technique. Monitor oxygen saturation and report trend. What do you think? Tracheostomy, stoma, LPN can take care of it. Positioning, throat breathing, UAP can do that. Teaching, RN. Monitoring, LPN. So this is the way you break it down. Don't make it delegation too much difficult. One word, find the answer. If you use so many words, you get distracted. NSC team consists of RN, LPN, UAP in the care of a client with NG tube for decompression, which task can be safely delegated to LPN. Delegation, right? Measure and record NG tube drainage. Irrigate the tube as prescribed. Teach client about NG tube care. Assist client with oral hygiene. I said MMR most. Therefore, if I monitor, reinforce, all are many things that can do. Since they can do with oral feeds and everything, they should be able to irrigate the NG tube. Assist with oral care. They can do that by this UAP, so UAP will do that. Teaching by the RN and measuring the output, the UAP. So these are little things I want you to master. What do you see? Same thing. We have a patient with ARDS who is on mechanical ventilator with high PEEP. What intervention can you safely delegate to the UAP? Can you safely delegate for the LPN? It's a select or apply. You don't over-select. Make sure it's there with what? MMR most. Monitor most, medication, reinforce, right? I deal with stoma, right? Those are the things. And 2 feet. So what do we have? What do I have? What do you think? Reposition the client every 2 hours to prevent pressure injury. There's no UAP there, so they can do that. Monitor and document skin integrity at the pressure point. There's no UAP there, they can do that. Adjust the ventilator setting to decrease PEEP. That has to be done by the RN. Apply a specialty mattress to redistribute pressure. UAP, LPN can do that. Assess for signs of skin breakdown. That has to be done by RN. How did you do? Delegation, NCLEX delegation. Now we're on Bowtie question, next generation NCLEX. I know you master it. Let's get to it. I love this question because you can't take the NCLEX without not knowing this problem. 80-year-old, he was brought into the emergency room by the daughter for being lost. That's the key. The age and lost in the park, and she has visited for 10 years. That means all of a sudden she's forgetting. This is the way you should read it. Daughter also reported near fire misses in the house, almost burned the house because she's forgetting things. Numerous episodes, not remembering where she placed her shoes and that room, having issue with short-term memory. Now having difficulty remembering everyone, including the grandchildren. Very good at remembering event that happened several. So remote memory is intact. Vitals is normal. Patient is alert. He had flagged affect, appropriate, neuro exams, no deficit. Taking omeprazole. You should know what is wrong with this patient. Is this depression? Is this Alzheimer's? Is it delirium? Is it Parkinson? It's a Bowtie question. How do you master Bowtie? Find the condition they're experiencing, then provide action to it and monitor your action. There's no evidence of depression here. Patient has no acute problem. This has been going on for a while. So Alzheimer's. There's no evidence of resting tremor. So this is Alzheimer's. If this is Alzheimer's, what are you going to do? If this is Alzheimer's, we got to give them donepezil, right? That's the treatment for that. Followed by what? Cognitive function to see where they are. Cogentin is anticholinergic, right? And then fluoxetine is SSRI. They don't have depression. Cogentin is good for Parkinson. And therefore, we're going to give them what? Prescription for donepezil, detailed cognitive function, and let's see what we did. So Alzheimer's here. The NPCL, cognitive function. And what are we going to monitor for? What do you think? Syncope because of the medication. And clonus if you take SSRI, right? And your heart rate. These are key portion of the urine color change is associated with congenital. But this is syncope and donepezil. Those are the signs and symptoms that it causes. So this is Alzheimer's patient. You have to be comfortable with them. The side effect of cholinergic is what? Seizures and bradycardia. We should not give them anticholinergic, which is what? Congenital. Okay, and it's used for Parkinson disease. That's your bow tie right there. 58. We are now in mental health. And this is assessing a client who is demonstrating the defense mechanism of undoing. Which of the following behavior indicate the client is undoing? What is undoing? Undoing means you did something wrong and you're trying to take it back. After yelling at the spouse, the client repeatedly apologized and bring the nurse a gift. Good. The client who cheated on exams begin volunteering at what? A community center to make up. He's trying to make up. The client insists they never felt angry after slamming the door. It's no regretting. After having hostile thought towards the sibling, the client buys them an expensive. Redoing it. The client blames a co-worker for their own mistakes, not undoing, still blaming people. It's a defense mechanism. Make sure you know them. And this is caring for 4 clients in the residential psychiatry unit. Mental health, right? Which client should the nurse assess first? That means bad problem. The kids. Client refused to eat dinner and skip breakfast. Okay. Client is pacing in the hallway and yelling. Okay. The client who cries during a group therapy. Okay. A client who attempted to smother a roommate with a pillow. Suicide. Bad problem. The rest are all okay. And this is assessing the client in the outpatient medical clinic unit. The client stated that I have no reason to leave. Bad problem. I have suffered enough. Bad problem. What is the appropriate response? What you should say? Don't answer the question. Let the patient talk. If you're talking, ask for more. Which one is asking for more? Tell me more about your statement. I have no clue. I'm not going to make you a friend, but tell me more. Who's going to take care of your family? That's not what the patient is asking. We all have to go through this. That's wrong. I'll get you a chaplain. You never ask for chaplain. That's how you answer therapeutic communication question. And that's the strategy. Are you ready? We're in 60. We have 13 more questions because of the case study. We did 3 case study and other ones. So those are all 6 questions. What do you think? And next, as a attended staff education program about phases of what nurse-client relationship. Know this. When you have to meet a patient, there's phases. Which phase the nurse prepare and gather information before meeting the client. That means I get information before I go and see them. Pre-interaction, termination, orientation, and working. What do you think? Pre-interaction is when you prepare to meet them. When you meet them, you orient them. And then termination, at the end of the time, you're discharging them. And working when you come out with a plan to work with the patient. And it's assessing the 12-hour newborn admitted to what? Nursery. This is what? Newborn. Which finding require immediate intervention, not unexpected finding. Bluish discoloration of the extremities with pink trunk and bluish discoloration of the extremities with pink trunk and torso. 2 centimeters umbilical hernia, a pulse of 100 beats per minute. Respiratory rate of 30 beats per minute. It's a newborn. What do you think? Which one you need to let the doctor know? Respiratory rate is normal. Pulse of 100, that's low. We need 110 to 160. Umbilical hernia and bluish discoloration are expected. So this is bradycardia for the kid. Which finding is concerning? And this assesses a newborn with moral reflex. That means stirring movement, right? But which of these is bad? The newborn cry loudly during the reflex. The newborn exhibits asymmetrical movement of the arm. Something is broken. The newborn arm extends and then return normal to the midline. The reflex is absent after the newborn falls asleep. What do you think? Stop the video, put down your answer, let me know, but keep track of your score. If I sleep, there's not going to be any moral reflex. If my hand returns to the midline, that's what's suspected. But if there's asymmetrical, it may be injury, right? Breakthrough process injury. A baby is born at term via vaginal delivery. If you need a bunch of newborn concepts, check out that class. Which action should the nurse take immediately after birth? After delivery, what should be your priority? Dry the newborn, perform a full physical exam, place the newborn skin to skin with the mother, assess the newborn airway for patency, give them erythromycin, obtain the newborn birth weight. It's very important. After delivery, hypothermia is most important. So every question should be based on that. Full physical exams is not necessary. Hypothermia, skin to skin with the mother. Of course, we're going to assess the airway. Erythromycin can wait, even though it's very important, but not this stage. Immediately, the word say immediately. We're going to get the weight later on, but it's not important. So these are very, very important information we should do. And this is assessing a client who has been treated with what? Dyspareunia, with oral contraception. Which finding the nurse should expect? This is painful, what? Intercourse. Therefore, what should be your right answer? Painful intercourse. No vaginal discharge, less painful vaginal sexual intercourse, decrease heavy menstruation, pain-free during menstruation. It has nothing to do with menstruation. Menstruation is what? Dysmenorrhagia. This is penetration associated with vaginal intercourse, and therefore is painful. And hence has provided teaching to a client, female client, about the best time to perform self-breast exams. Which statement indicate correct understanding? When should you do breast exams? These are concepts I want you to know. This is the reason why it's related to your menses. I'm giving you a clue. If you do it before your menses, your breast is going to be tender. It's going to be what? Cystic in nature. It's not good. It's after your menses. Not 3 weeks. It's too late. Not the week before. Your breast will be bumpy. It's after your menses. It's going to get softer. The hormones are low. Maternal health. And then it's caring for a client receiving Pitocin. Observe this fetal monitoring. Which action should the nurse take? EKG. What do you think? Stop the Pitocin, place the client in a knee to chest position, place the client in lateral position, notify the air care provider. What do you see? I'm getting Pitocin. If you see this fetal arch strip, always look at the bottom and see what is the contraction. 1, 2, 3, 4, 5, 6. 6 contraction. You're only supposed to contract 5. That means the baby is in trouble. Too much. Tachysystole. If there is tachysystole, stop the Pitocin. You don't need to put them in the knee to chest position. If there's what you're looking for, first you stop the Pitocin. If it's a late D cell or what placenta insufficiency, then you can put them in the knee to chest position or lateral position, depending on which condition is at presence. And you can stop the IV fluid. You can give them IV fluid, give them oxygen, and then let the doctor know. But first thing we should do, stop the Pitocin. Parent of a 7-year-old asks when to the expected first tooth to show up. It's very, very important to know that first tooth, 7-month-old, when did it show up? It's unusual to have a tooth before 12 months. The first tooth usually comes in a 10 months. You can expect the first tooth around 6 to 10 months. Babies don't have teeth until they walk, right? Definitely 68. D is wrong. Know this, 6 to 10 months, that's when you get it. Pediatric, this is pediatric. Most of the information are straightforward. So you should take a picture of this and write it. This is a common sense tip. It comes around the time solid food start, right? If you want to start solid food, that's when they start having teeth. And usually think about 6 months, spoon the teeth. Adolescence is newly diagnosed with what? An adolescent is newly diagnosed with what? Life-threatening condition, bad problem. Which reaction should the nurse expect from adolescent? How are they going to react with the sad story? Are they going to be happy? Are they going to think magically? Believe that death only happened to older adults? Emotional detachment and little concern about death? Awareness of the personal mortality and the risk-taking behavior? Magical thinking about escaping death throughout wishing thoughts. You know, preschoolers have magical thinking. Adolescents, they're usually aware about the problem. They think like adults. Which of these think like adults? They are aware of the situation and they have to know about it. 15-year-old asks caring nurse when the child will be ready for toilet train. This is key. How can you go to the toilet train? How can you do that? Toilet train occurs when the child has sphincter control. When the child expresses the urge to defecate, if you can do that, when the child expresses the urge to defecate or urinate, when the child can follow simple command, when the child can ambulate to and sit on the toilet, when the child can put clothes up and down. Think about it. If you have a child who want to go for toilet training, which of these do you think you need to satisfy before you can do that? If they have sphincter control, that's good. If you want to tell you that they want to go, that's good. If you can follow command, you said, hey, go to the bathroom, they will do that. If they can ambulate to the bathroom, that's good. If they can put their pants down so that they don't poop on themselves, that's good. So that's what they give them. 3 more questions. This is basic care and comfort. Basic care and comfort. Make me proud. And NCC evaluating a client and are going on oxygen therapy. Which of the following statements indicate teaching is being effective? You have to know certain things about oxygen therapy because of what? Combustion, fire. I will keep my oxygen tank about 5 feet away from any heat source or open flame. I can use petroleum-based products like Vaseline to what? Moisturize my nose if it feels dry. I will clean any nasal cannula tubing regularly as instructed by the healthcare provider. I will make sure not to smoke or let others smoke near the oxygen. It's okay to adjust the oxygen flow if I feel short of breath. That's wrong. It's wrong because if you use oxygen, there's certain things we got to tell you not to do. That one is completely wrong. I will notify the healthcare provider if I experience shortness of breath or headache, right? So that is toxicity from that. I will store my oxygen tank upright in a well-ventilated area. That's a good thing to do. Therefore, store them in the well-ventilated area. Let me know if you have shortness of breath. Don't titrate it, don't increase it without instruction. Make sure there is no smoke, nobody smoke or you smoke. You clean the canister, nasal cannula regularly, right? Petroleum gel can cause fire, and therefore 5 feet away. That's fire for you. And this is teaching a client about left-sided weakness, how to use a cane. You got to know cane, right? Very important, teaching the patient how to use cane. Which of the following statements indicate ineffective teaching? If you use cane, the client places the cane on the right side. What's the problem? He has left-sided weakness. On the right side, what do you think? The client holds the cane in the left hand to support the weakened side. The client moves the cane forward with the affected leg and then step with the unaffected leg. The client uses the cane to help support their weight while walking. The client places the cane on the left side and moves it forward with the right leg first. This is usually, it requires some critical thinking by common sense. Just know that cane, I give you cane not because of the side that is weak. That's number one. Therefore, if you put on the side that is weak, is wrong. Patient have left-sided weakness. Therefore, which one indicate ineffective. If you place it on the left, it's bad. You move the cane forward with the affected, right? The good leg, you're using the cane, right? And the affected leg because the good leg can support you. The client uses the cane to help support the weight while walking. And the client places the cane on the left side and move it on the right side. So that's wrong. Last one, 85 question. English practice question. High yield question. Questions that show up most of the time. This is evaluating a client undergoing sleep hygiene practice. Which of the following statement indicate teaching was effective? How do you sleep? And which one is good? I'll go to bed and wake up the same time every day. Good. I will avoid caffeine and every meal. Good. I will use bed only for sleeping and not for watching TV. Excellent. If I can't fall asleep in 20 minutes, I'll get up. Good. I'll make sure to exercise vigorously. No exercise before you go to bed. If you have to, make sure it's like 4 hours below, 4 hours above. I'll create a relaxing bedtime routine. Excellent. And I'll keep the bedroom dark because of light. This is adapting class. If you reach here, thank you for going all the way. I hope this video helped you. I know you find your weakness, and I know you're ready to tackle it to pass this NCLEX. And if you like this video, look on the screen. The next one is another 85 question content review to see and practice that one too to help you pass your NCLEX. Take care of yourself. Bye.